a professional researcher. And our goal within PACS is not to train folks who are going to be clinician scientists who are going to make their living doing sophisticated laboratory research and major randomized prospective double-blind studies. We want to train our trainees to think critically. We want them to be able to critically analyze an article. They need to be able to break it down into constituent parts. What is the question that the researchers are asking? Do they have a question? Do they answer that question? Do you believe it? We need to drill down. Do they prove it convincingly? Are there confounding variables? Do they have quality or not? And are the various groups equivalent? 50 years ago in the States, a study came out that said this cough syrup was very, very helpful to prevent pulmonary issues in people. And it was an advertisement. And they quoted a study. Well, if you drill down to their study, one, they were very biased. And they had one group of people who were in their 80s in a care facility who were not getting the syrup, and they had a group of collegiate athletes in the other group who were getting the syrup. And then they said that the health benefits from taking the cough syrup was excellent. Well, that's just fraud. That's not research. That's fraud for commercial purposes and gains. So we have to say, we want to help improve our trainees to be able to read the literature and not be confounded by it, not just to read the conclusion and the summary, but to look at the materials and methods section, to look at the statistical development. Are the groups equivalent or not equivalent? Is it blinded or not? It doesn't need to be. It doesn't have to be that sophisticated. Change a paragraph because I'm very nonlinear. In 2015 or 2016, we attended the Pan-African meeting between the Association of Surgeons of South Africa, COSEXA, and WACS at the Africa Union Building in Addis. And we met there with colleagues from various parts of the sub-Saharan Africa. And the instructions there were very great. But one of the points that was made there, that Africans will solve Africa's problems. Africans need to be involved. We need to do our own research. We don't need to be colonialized. And there's a whole literature right now about neo-colonialization, and some of that I will address. So to reiterate, we in PACS want our trainees to become teachers and leaders. And many of our trainees will become our own faculty and our own program directors and our leadership. They will need to know the basics, the vocabulary, to better train and teach and equip their trainees if they have that information themselves. So that is one of our purposes. We don't want to be dependent on outside people like me and like many of the people who are currently involved in most of the research. There are very good models, and I know West Africa probably better than I know the COSEXA region, though I have been working with COSEXA off and on since 2016. But I know for sure that there are robust research efforts in Nigeria that have been equipped in part, catalyzed in part by people from Memorial Sloan Kettering Cancer Institute in New York City. But the goal there is to train and turn over, and that's what they've done. Also in Ghana, there's been great work done by colleagues from the University of Washington who have trained and then turn over, and they are basically trying to improve the indigenous research productivity, addressing problems within those countries as they seek to move forward. So next, I'm going to read a document that Kat Chu wrote. I will read it slowly. And then I do want to leave time for us to have some dialogue at the end before my time runs out. So I'm keeping an eye on the clock as well. So this is not my original work. I tell people I've had no original ideas, very few. Probably the most original idea I had was when I got to Nigeria in 1978. We had no stoma therapist and no stoma bags, but we at times had to have colostomies and even ileostomies at times, and that's a huge problem if you don't have stoma bags and if you don't have stoma therapists. Well, we had a problem. What are we going to do? Well, we made a colostomy bag out of a tin can, a milk tin can, cut out both the top and the bottom, a part of an inner tube, a string, and a nylon bag, a bread bag. And we were able to make our own local appliance, if you will, and train our patients how to use those so that they would not have a continual discharge going forward. We had a problem. We looked at our local resources and we came up with it, and it actually got published in a leading journal in the United States. So again, you identify a problem, you look at your local resources, you think, you discuss with colleagues, and it's better to have a team instead of to be a lone ranger. So let me start out next with reading a few paragraphs from Kat Chu as we relaunch our research committee within PACS. PACS has the mission to train surgeons to work in sub-Saharan Africa, where surgical diseases are common, but resources are limited. There are a paucity of data on the surgical burden and case mix in the local African context, without which the planning of needed human and other resources are difficult. In addition, understanding which treatments work best and the type of outcomes patients are achieving without good data are not possible. Data collected in the context of operational research is more powerful if it can be collected at multiple sites using the same universal tool to ensure statistical power and inter-site comparability. PACS is well positioned with its footprint in 12 different countries as a leader in surgical research for sub-Saharan Africa. In addition, a solid foundation in research methods and scientific writing can improve clinical acumen. The ability to critically analyze and interpret the research of others, to know what to adapt and adopt and what to discard, can improve our own clinical practice. In addition, the ability to formulate a scientific hypothesis and test it can drive innovation and improve patient care. PACS residents have an opportunity to use research to enhance their clinical training. Furthermore, PACS can also develop African leaders in surgical research who can set their own research agendas, making collaboration with those outside the continent more locally relevant. So PACS has research requirements for all of our entries, and formerly we used to send our final year residents to Greece for a conference, but obtaining visas and expense, that has not worked out. And so now we hold a conference for our penultimate year trainees. We have both residents and fellows. And we do that at Brackenhurst, Kenya, just north of Nairobi. And the participants are to at least bring a poster, and there's a competition and all of that. So carrying on with Professor Chu, a glory of medicine is that it is always moving forward, that there is always more to learn. PACS seeks to instill in its trainees a thirst for knowledge and discovery, hoping they will be observant, leading to comments like, "That's odd," followed by, "I wonder why that happened," culminating in action to discover the answers. This process is foundational to training and lifelong education. One of the best ways to learn such a process is through exposure to, participation in, and the leading of research projects. PAC's role in the medical education landscape in Africa continues to grow. We're continuing to open new programs. We opened a new program in southern Angola this year. The landscape has been dominated historically by masters in medicine training programs across Africa that require a thesis to graduate, which is similar to a research program. So let me just say that when I started to talk about the meeting at the Africa Union in Addis back in 2015 or 2016, that Kat Chu and I met at that time. And she invited my wife and I to come to UCT to give a talk to their MEd trainees. And many of you are MEd, but COSEXA grew up in large part to train people outside of the academic university teaching medical centers at faith-based hospitals, at district hospitals, and at other types of facilities throughout the sub-region. But the invitation was to come and speak for 2 days to their trainees, and the topic was to be how to survive my MEd. How to survive my MEd. What happens in those days, that usually the programs were 4 years in length. People had been done their 1 year of national service. Often they had worked in district hospitals, Ministry of Health hospitals for 2, 3, even 5 years before they could even get into a training program. And so they came there and they were told, you have to do this research project. Well, the first year or two, they were learning the system. They were learning the new hospitals. They were learning the faculty and the attendings, and they didn't start the project. Then the third year and the fourth year, when they should be strengthening their clinical skills, they said, oh my gosh, I've got to get this research project done or I'm not going to get my fellowship. And so then they would divert their attention and panic. And one of the big problems is that what am I going to do about statistics? What kind of study am I going to do? So how to survive my MEd, and it became a burden which was thrust upon them to try to finish this in their last 2 years. So we want to do this better. We want to talk about having a timeline. You need to, if you have a requirement, right now there's no specific requirement to publish. It's interesting, in those days, going back 8 years or so ago, the requirement was that you had to publish something. They changed that to have a document suitable for submission to publish, which took a lot of pressure off of our people. But that was the introduction to the MEd programs. And I was actually asked to start an MEd program in Botswana along with my colleagues, which is very difficult to do. But we basically talked them into joining COSEXA, and now Botswana, I think, is the most recent member, perhaps, of COSEXA, and we are actively involved in COSEXA as well, and our trainees in that residency program are taking the COSEXA exams. So the landscape has historically been dominated by Masters of Medicine training programs across Africa that require a thesis to graduate. And that's really the master's thesis is really a research project. Research education in a basic form is now required part of COSEXA curriculum and is incorporated into the MCS online modules. For years, even decades, research within Africa was minimal. More recently, there's been much research done by non-Africans about Africa. This approach has now been exposed as lacking collaboration and hampering the development of research capacity within Africa. PACS being at multiple sites, we have 24 programs in 12 countries or so, with further growth anticipated. PACS has a unique position to catalyze multi-site transcontinental research projects to answer questions that remain regarding medical education, healthcare approaches, and treatments in Africa. And I would say that COSEXA institutions, whether they're non-PACs or PACs, I think we can collaborate. If you have information, if you have a research project from one site, that's nice. But if you have a multi-site participation, especially across our subregion, that is much more powerful. It has a better chance of being published if that is your rationale. So with this growing role and impact comes a responsibility to contribute to the body of literature coming out of Africa. So our goals in PACs, and I'm going to come to greater COSEXA and some other issues momentarily, is to create and maintain an organization-wide effort to support research. And that's what COSEXA is doing, having this series of talks and you attending it. And there are 271 attendees at the present time. That's incredible. But we want to create and maintain an organization-wide effort to support research, and COSEXA is doing that. We want to support the research efforts of trainees, especially at the smaller programs. If you're at a university teaching program that's in COSEXA, that's one thing. If you're at a hospital like AIC Kajabi in Kenya, or Tenwik Hospital in southwest Kenya, or in Bingo in the northwest province of Cameroon, there are robust research initiatives in those institutions. We want to catalyze multi-site research, and we want to contribute meaningfully to the growing body of scientific literature coming out of Africa. Those are some of our goals. Principles for COSEXA and principles for PACs are similar. I mean, we're all joined at the hip. We both, PACs and COSEXA, started within 1 year of each other, and we have been together essentially since 1996, 1997, 1998. So the principles are excellence, scholarship, and integrity. We have different structures, but we do need organizational champions, and COSEXA is providing that through the Secretariat in Arusha. And we want to increase and catalyze the experience in research within Africa. So it takes personnel, it takes funding, it takes persistence, and we have different guidelines to carry us as we go forward. So those are some of the background things that I wanted to state. There's an article that we will share. I will send the article has just come out in Clinical Teacher. And if you want to write this down, you can, because you can look this up. But individuals who are located in the University of Johannesburg and at the KwaZulu-Natal and Durban, so South Africans, which are not part. I see that hand there. Let me finish another word or two, and then I will ask Mohammed El Amash to ask his question. This article is in Clinical Teacher this year. It's available for downloading, the entire article, and the code word is E13806. But I will be forwarding this to the Secretariat, to our leaders, and you should be able to obtain this. So the title of the article is How to ... do decolonial research. How to do decolonial research. And they make several points. First, they say modern medicine and health professions research, they call it HPE, are rooted in coloniality. Number two, coloniality is the legacy of colonialism seen in the continued domination over and oppression of knowledge. Number three, if the field of health professions research is to be truly equitable, diverse, and inclusive, then coloniality must be undone. Number four, decolonial research starts with critical consciousness and reflexive practice, and they will define those terms for you. This is really important. I think it's number five. In research, adopt the position of learner. Let me repeat that. In research, adopt the position of learner. Next, decolonial research seeks to benefit the communities it partners with. I'll come back to that. Decolonial research must be democratic, participatory, and emancipatory. And then finally, the impact, instead of the impact factor, academic autonomy, and personal gain, we need to prioritize social accountability. We all know so many people from the West who have flown in, used the local research data, used the people to give them access to the data, wrote their articles for their own promotion, and sometimes did not even include the participants from Africa in the authorship. And if they're in the authorship, they were usually, as we say, caught in the middle. They were not the primary author. They were not the senior author. And my wife has written extensively on trying to increase the number of our African colleagues who are either the first author or the senior author, because that is important to them just as it's important to academicians in the West. But our focus is not necessarily on ourself and academic promotion, but is on solving problems for our patients and our constituency. So I will put this in the chat, and then I'll also send this to our leadership, and they can distribute this to everybody. I think the article is well worth reading. Let me just make one or two other points, and then I will take a question or two. One thing is, in the first sentence that I read to you, I review a lot of articles. My wife and I both review a lot of articles. And so in the second sentence from Kat Chu's document, she said, there are a paucity of data on the surgical burden and case mix in the local African context. One of the things I noticed, and this is one of the things we want to practice quality research, and I'm a little bit of a pedant, but the bottom line is that data comes from the Latin, and data is plural. So one of the things I often have to write back when I am reviewing an article is to correct some of the grammar, some of the spelling, clarify some of the things. But here's a sentence I want to leave with you. Datum, D-A-T-U-M, is singular, semicolon. Data are plural. That's a little thing, but attention to detail as a surgeon is very important. Datum is singular. Data are plural. So that's pedantic, I admit it, but I think it's important because we want to be grammatically correct when we write our documents, when we submit our abstracts. And so we're 40 minutes into my 45 minutes or so, and I want to answer questions if I can. And so we had a question that was asked. I saw that hand. If we can unmute the colleague who wanted to ask a question, let me see if I can answer it or a comment. I see a hand up also by Hassan, who is a co-host.
Yes, can ask now, Hassan.
Go ahead, please, sir.
Yes, and I will ask you for a question based on research. And when we are comparing to datum, you said datum is singular. Data is a plural.
Correct.
And this grammatically incorrect. This grammatically correct. How do you gonna find this incorrectly grammatically? How do you gonna find?
I think that can be a challenge. I quite frankly, because we're going through multiple languages, and those terms are actually from the Latin. They go back distantly. I think that one of the ways we do that is by having meetings like this and sharing things. That's a minor point, but it's just one point that there's so much to know, so much to learn, and that's not critical. Here's what I think is the critical thing. You need to ask a good question. You need a question and do a project that is doable within the resources that you have and the time frame that you have. It is unrealistic for one of our trainees or one of my residents at Botswana to do a basic science research project dealing with sophisticated changes at substitutions at 13Q genetic code related to some research project. We don't have the infrastructure in the background in Botswana to do that. We need to ask a question that's important for us in sub-Saharan Africa. And then we need to say, what is my time frame if I'm trying to write a research project or to get something published? Do we have the wherewithal to accomplish this within a 2 or 4 year period? So I think that that's the important thing. I think meetings like this are helpful. There'll be some major points that come up. The data point is a minor point, but it's just one that I wanted to mention while I was here. So I don't think that's critical. My wife is not only a librarian, but she majored in English, and her strength is critical analysis. But we want to read the articles carefully and not just read the abstract, not just read the conclusion. I think it's really important to learn and to focus on the materials and methods section and how the research is set up and what is the question and do they answer the question. I think that's pretty simple. And then do you believe it? Because we don't always believe it. And sometimes it's not significant. I mean, do we even need to be wasting our time perhaps doing this? But I would ask my wife. If I'm not sure, I would ask somebody else. And hopefully having conferences like this, you will be able to ask questions as they come up. So there was another question that was asked earlier. I saw another hand that was up. If we can let those people speak, and you can also put things in the chat box. I don't have much time left. I have 1 or 2 things that I want to close with, and then we'll go from there. And I see that well, again, he mentioned that I had aphorisms. If they will, okay, there's Abraham. Yes, Abraham. Can we unmute Abraham so that he can ask a question?
I don't have much to say. First, I will give you a thank. My question is, you mentioned a point of that a student should be adaptable to the position of learning. So, like, what do you really mean by the position of learning?
So can you repeat that last part of the question one more time?
There was a point you mentioned about how to do decolonial research. And then you mentioned a point that the adaptation of the position of learning. So I was just curious to know, what do you mean by it?
I'm not sure. Let me just say, and I see that people have talked about the 6 points, and I can type the 6 points in and and where the article is from. I think let me just say there are probably 100 articles out there right now on decolonializing of research in sub-Saharan Africa. This one is just out, and I found that it is quite excellent. Let me just also say that as you go through your training program, you're going to have attending surgeons that you're going to learn from. You're going to learn from your senior colleagues, and you're going to learn from one another. I think on the research front as well, that's a different skill set. You know, as you go into your surgical training, and you're not all general surgeons, I realize, you're going to learn to do different procedures. But just because you can do an open operation doesn't necessarily mean that you're excellent at endoscopy. You'll need somebody else who's going to help teach you how to do safe, appropriate upper and lower endoscopy, perhaps. Well, I think very few of us have a real mentor, but we do have advisors and we do have teachers. And so just as you have a clinical open surgery instructor, you may have a minimally invasive. This program is in part sponsored by Intuitive, which does robotics. It may be that you'll have a different instructor who's going to help you as you acquire skills through simulation and observation and reading to do minimally invasive. And you may need somebody else like Professor Mwachiro, who's going to help you do your endoscopy skills. Well, in research as well, you need to find somebody who can be your coach, who can be your advisor, somebody who can be a sounding board. And I think that that's one of the important things that I'm going to say here. I will put my email address in the chat box, put the title of this article in the chat box, and we will see that you get this. So I hope that that will suffice. I'm not sure about the question that you asked, and I'm hedging on that because I'm not exactly sure the intention, but I think if you read this article, which I think is a very good one, we've already started using the chat box to share information, and Ahmad has mentioned that Grammarly is one resource, and I will tell you that the language issues are different. I mean, many of you are working in maybe your third or fourth language. That was true for us in some of our training programs. Lusophone, we've got people from Angola who speak their local language. They speak Portuguese, and now we're teaching them in English, and COSEXA is set up to examine in English. I always am, I won't say fearful, but I feel for the people who are Francophone who, when they take an oral exam, they've got to go through 2 or 3 filters to hear the question and then to express the question. I'm speaking in English. I've studied German, I've studied Latin, I've studied Greek. I know a little Yoruba, and I knew greetings of 3 or 4 languages, but language is really a big deal. And there are resources, but there are also people who can help you. And so you need somebody who is your coach or your advisor, who is helping you with your research project, especially if you do the early ones. And I think what COSEXA is trying to do is to create a culture of being inquisitive, of asking good questions, and then trying to set up research endeavors to answer those questions. Let me just say, I'm on Google a lot, and there's actually a very good history of COSEXA on the website. If you go to the COSEXA website, they will talk about our history. One of the former presidents of COSEXA at the Rwanda meeting several years ago gave a very strong, excellent description of the history of COSEXA, which grew out really of the East Central African Surgical Society, which was mostly in the teaching hospitals, the university teaching hospitals, but there's a wonderful history of COSEXA, and it is making much progress throughout our sub-region. Again, I'm watching the clock, and at max, I've got 10 more minutes, I think. If you could let Morale Mark ask a question. Can we unmute
Yes,
Morale Mark so that we
can unmute and ask your question.
Yeah, good afternoon, colleagues and professor. I just need a reminder on the 6 how to do the colonial research. There were 6 bullets given, so I'm missing. So I need them in written if you don't mind, or more understand. Thank you.
Perhaps you could put that I didn't hear all that. I'm 10 time zones away, so I started at 5 a.m. here, and it's almost 4 p.m. where you are. It's almost 6 a.m. where I am. So I'm having some connectivity, and I don't hear everything. But if you put that in the chat, I will try to address it if I can, and I will put some things there. Let me just conclude my section as we go forward. I'm 80 years old this year. And as I look back on I call it my vocation instead of my career. Let me make 2 points here. I'm going to preach a little sermon here, but I'm not going to take up an offering. There's a difference between career and vocation. The word career comes from a Latin word, carrare. There's actually a Porsche that's called a Carrari. And that was the name of the racetrack outside of Rome, where people went round and round and round in circles for transitory fame and glory. Vocation, on the other hand, is your calling. Why are you on earth? What is your why? What do you hope to accomplish? I often ask my students and my trainees, what do you want written on your tombstone? What do you want for your epitaph? He took great vacations. He had an antique car collection, or he took care of sick folks. He took care of widows and orphans and immigrants and the have-nots of the world. What do you want to be remembered for? So here's my bottom line. At the end of many of my talks, and I give many, I will tell the audience, I think I am the best paid surgeon I know. I just get paid in different currency. My currency are my residents, my trainees, my medical students, and my patients. And they're all tax-free. I don't have to pay any taxes on any of those things. So I think we're the blessed ones. I mean, we had parents or families or communities that helped us become educated. We didn't have learning disabilities. We struggled probably to make it, but we were able to obtain a medical training. Now you're getting training in residency where it's oral, maxillofacial, or other. But we are among the blessed ones. Can we pay it back? Can we pay it forward as we go forward? And I'm encouraging you, it's not about titles, but I really encourage you to see that we have the opportunity to make a difference as we go forward. So some of the aphorisms I have, and I will send the list of those if that can be distributed. But some of those are, if you argue for your limitations, they're yours. Again, I have no original ideas. That's from a guy named Richard Bach. If you argue for your limitations, they're yours. If you say you can't do it, we can't do it. If you're like the little train that says, I think I can, I think I can, I think I can, then you have a chance. You're still in the game. That's one of the quotes I live by. I think it's important for us to invest in people. And I think that is really it's an equity investment. It's difficult, but it's very, very rewarding. But I'll send a list of things out. I've got another meeting I have to be at in about 30 minutes. But I will put my email address in the chat box, and I'll try to I'll put the link to this article. I'll get the article, make sure you get the article. And I see other questions that come up, but my time is pretty much out. But I think that I will turn it over to our leadership now, and I will try to stay in touch, and you can contact me. And again, I'm looking down here. We're up to 275 participants at the present time. So I will put some comments in the chat box to everyone. And if I will turn it back over to our host and co-host. Thank you all very much for tuning in. I never dreamed we would have 275 people, but this has been wonderful for me. And I look forward to seeing you in time at COSEXA meetings the first week of December. I help write questions. I'm one of the examiners and I've been working with COSEXA pretty much since 2016 or so. God bless. Thank you very much.
Thank you so much, Professor Tarpley. We are really honored to have you. Thank you so much for leading our first session, our opening session. Now we'll turn on to our next speaker, Dr. Paul Okeny. Dr. Paul Okeny, if you can unmute yourself, and I have given you already the access to sharing your PowerPoint. If you have one, please go ahead and welcome. You can introduce yourself, and then we can click on our meeting. Thank you so much.
Hi, good afternoon. Can you hear me?
Yes, we can hear you.
Right, okay. Right, I'll begin straight away. Thank you. Thank you, Godfrey, for the invite, and thank you everyone for coming around and to attend this session. My name, excuse me, my name is Paul Okeny. I'm Ugandan and based at Mulago National Referral Hospital, a COSEXA fellow. I was assigned to share with you, or rather have a discussion with you regarding anatomy of a research protocol. I'll just go straight to my PowerPoint presentation. I've prepared a PowerPoint presentation, which shouldn't take long. Most of the things, I'm sure many of you have already come across them, so most of it will just be a revision. I thought we should have this talk as seen there. That's the outline. We'll kind of touch on what a research question is, and then we'll go down to anatomy of a research protocol, and I will conclude. I hope I won't take more than 20 minutes of your time. I hope that by the end of this session, you should be able to define the characteristics of a good research question. The previous speakers has been talking about the importance of, coming up with a good question. So I hope that by the end of this session, you have an idea about how a good research question looks like, what are the different ways in which you can come up with a good research question, and what are the different components of a research protocol or a research proposal. Right, so research questions. I'm sure we all know what a question is, and you probably, yes, the previous speaker has talked about what research is. A good research question, it helps you, it's like a map. It helps you in writing your proposal, planning your study, and it actually helps guide what study design you're going to use and what statistical analysis you're going to perform. In the next couple of weeks, you're going to learn about the different study designs, the different possible statistical applications and statistical analysis that you could perform during when you're conducting research. Yeah, so that's essential. So a research question helps guide you in all these things. And that's why a research question, a good research question from the start is very important. And if we get it wrong, many times we get lost along the way. Then we have to come back to the drawing board to review our questions. What are the characteristics of a good research question? Well, some scholars have proposed the acronym FINA. FINA acronym then stands for feasible. So it means that your question needs to be feasible, interesting, novel, ethical, and relevant. And I think those are English words, and they should be quite clear. And the previous speaker, Professor Tarpley, has actually mentioned, touched on 80% of this. What I only want to say is that your question needs to be ethical. Because our research and methods, which is guided by the research questions, need to be ethical enough. For example, you cannot say does living, when you're doing appendectomy, for example, do patients who have their stump unclosed or not closed do better than those who have their stumps sutured or ligated? I mean, that is really unethical. I know it's a foolish question, but it's just an example of an ethical question. And there are many others ethical issues that you can come up with. And the question needs to be relevant. The previous speaker talked about the resident, designing research to look at, chromosome positions, genetic study. I mean, it's not a bad research, but what is the context in which you're working at? What is the relevance of your research question? How is it going to be used? Yes, you can do it in another environment and come and apply that research in a different context, what we would otherwise call applied research or applied health sciences research. So that is fine. So a good research, a good question should be feasible, interesting, novel, ethical, and relevant. I mean, recently other scholars have said, you should add the word maps. So there's also finer maps, in that it should be something you can manage. If you are in Uganda, you don't have funding, and your research proposal is going to cost you $1 million, then that's not manageable. So you have to get something that is manageable. Another, you could say feasible as well, but manageable, something appropriate and of potential value. It may not be of value right away, but should be of potential value. So the questions must be specific, measurable, and realistic. Again, this was touched on by the previous speaker. When you ask a question, what exactly do you intend to do? And how do you intend to measure it? How do you know that you have achieved what you intended to achieve? So what are the variables that will tell you that you've achieved, and how are you going to measure the variables? Is it achievable? So in the sense, it makes it sound like a research question is going to be very, very long, but no, we have to find a way of condensing it in such a way that it is specific. We have something we are going to measure, and it's something realistic and feasible. Many of you could have heard the acronym PICO. P standing for patients, problem or population of interest, and I standing for intervention or exposure of interest. C standing for the comparison or the comparative intervention or the comparative exposure when appropriate. O standing for the outcome of interest. And more recently, the word T standing for the follow-up time that you intend. So it's what I would call the anatomy of a research question, that a research question should have those elements. Which population are you looking at? What intervention do you want to put in? Do you want to apply? And how do you know that your intervention is effective? You can only know that if you have a comparative group. So that's a comparison. So the comparison could be a standard care. Then the intervention is what you're introducing in your research. And what is the outcome of interest, and how are you going to measure it over a period of what time? So that is PICO. It's quite a popular way of understanding this. After this, you can go and read more about it. And there are other acronyms that you can use to guide the way you frame research questions, whether your study design is qualitative, quantitative, or mixed methods. It's all covered in here. Now let's move on to the physiology. Now I just included physiology here so that you can understand how this plays. This is just my opinion that physiology refers to the type of the question that we are going to ask, and which is determined by the intent of your research. Is when you're doing the research, are you trying to is it a diagnostic problem? Is it a prognostic problem? That is, are you trying to anticipate the patient's likely cause? Is it an issue of therapy? Is it an issue of prevention? Or is it education? So all these determine kind of how your research question plays out. And below I give examples, or above rather, I give examples of each. I may not be able to read through all, but let's look at point number 1, intervention or therapy. So keep in your mind the acronym PICO, where P stands for patients or population or problem, I for intervention, C for comparison, and O for outcome of interest. Now look at question number 1. In the aged population, what is the effect of exercise programs on accidental falls as compared with no exercise? And if you take a minute and try to identify what is the population there, what intervention are the researchers putting in place, and what is the comparative group, or what is the comparison group, and what is the outcome? What is the outcome that they're looking at that differentiates these two groups? In a minute, you'll find that the population there is the aged population, so the elderly, for example. Of course, here they haven't given us the exact age, which also says it's not a very specific. So here we're supposed to have the exact age. Are you looking at, those over 65? You're looking at the elderly. Now, the elderly, you can use the word elderly if there's already a known or standard definition of elderly in your context. So if, for example, in Uganda, our policy says the elderly are those who are above 65, yeah, then I'm free to say the elderly. But when you're in your description, you'll explain what elderly means. In the second question, in patients undergoing emergency abdominal surgery, does use of separate sterile gloves or instruments to close wounds result in reduced surgical site infection at 30 days post-surgery compared to routine care? So you can see that the comparison there is routine care, and the time period is 30 days post-surgery. The study population is patients who are undergoing emergency abdominal surgery. And what is the intervention? I'll leave it to you to find out. So that's an example of using PICO. And you can apply this to any research question, especially those involving intervention or therapy. And there are other types, forms of research: etiology, diagnostic research, and prevention, prognostic, and you can apply it in all different types. Now, what are the theoretical concepts that underlie coming up? This issue of coming up with the research question. I know you may have asked someone or yourself, how do I come up with a question? Now, there are some underlying theoretical concepts that may help us in coming up with a question. When you deal with patients continuously over time, and you read continuously over time, you ask yourself certain questions and you seem not to find answers to those questions, then those might be the grounds for coming up with research questions. There are two ways. One is called gap finding, and the other is called problematization. Gap finding, as the word sounds, or the phrase sounds, is just identifying gaps in literature that you think have not been filled or that are incomplete, and you want to, you want to help it, you want to kind of say fill in the gap. Whereas problematization refers to challenging existing assumptions in the literature. And I'll try to look at each one of these separately. Now, how do you find a gap in the literature? I have borrowed a theoretical framework that was proposed by Taylor and Hamdi in 2013. This is based on previous work in 1984, what they call experiential theory of learning, and by John Dewey's learning by doing. John Dewey was a very popular American psychologist and educationist in his time. I'm not sure whether he's still alive now, but I don't think so. So in this, you see that the way we come up with, you identify gaps is first you're given a task to perform. Let's say you're a COSEXA trainee or doing your MCS or FCS on your own call. And you find that all the patients you've been working on end up getting surgical site infections. And so as you go back home, you reflect and say, but why could this be? It's not, it's out of the routine. So you reach what they call dissonance. What you expect is not what you find. So you're disturbed internally. So you go on to reflect. And as you reflect, you keep observing. And as you observe, you develop certain ideas based on your reading. And after you develop those ideas, say, okay, is it because we are not sterilizing our instruments well? Then you set out to investigate that. You can do an experiment or you do an observational study. And once you get back your result, you reflect on what you found and consolidate your results. And you add to existing knowledge, either your own existing knowledge or existing knowledge in the research community. And the cycle continues. And once you've done that, you get feedback from your colleagues and you go back to the ward, you identify another problem and the cycle continues. So it's about learning by doing and what is called experiential learning. That's ideally how we should come up with research questions. In this way, you get something that you're passionate about because you have experienced the problem, you have experienced the difficulty. As opposed to just going online and picking up some research question randomly by, which was put there by someone. You may not have a very deep connection with that question. What are the different types of research gaps that you can find? Different scholars have given different types of research gaps. And I know it can be a problem, especially if you're applying to a university and you're trying to write a dissertation. They keep asking you, what is the research gap? And you can run out of words, but to your left on that table, you can see the different types of research gaps. There is the evidence gap, the knowledge gap, the methodological gap. For example, if a previous study, a similar study has been, let's say it was a cross-sectional study, that's a different method. Now, if you're coming in with a cohort study, that's a superior method, and therefore, that's the gap, and you're justified to do that. It's a theoretical gap, and there's a population gap, and the likes. Again, this just tries to bring into context where to find the gap. You have past knowledge from your reading. There's something that you expect to find on the ground, but you don't find it, and there is the gap. Does the gap make sense? Is the gap theoretical? Is it a difference in theory? Is it a difference in practice? Is it a change in the prognosis of a disease? And that's the gap that you can investigate. And it's from that gap that you come up with meaningful and relevant questions. Now, problematization is a little bit different. People argue that gap finding just reinforces the existing theories or the clinical practice or clinical evidence. It doesn't challenge existing theories. you know, and so it just keeps, it's incremental, so to say. Whereas problematization tries to critique, tries to come up with new concepts, new theories challenging the status quo. You know, and people think that this way of approaching research might be more meaningful. However, young people like you and me might find it risky because of not having a name in research. You might find it difficult to find someone to fund this kind of, you know, risky research, which opposes existing knowledge, because they can create conflict between peers and among scientists, among researchers, and among editors. How do you come up, how does problematization work? This table tries somehow to show you the steps of how to problematize, if I may use it. It's a bit of a difficult English word. Yeah, but at the end of it all, you want to question the assumptions, the existing assumptions. And once you've questioned the existing assumptions, you try and judge and say, can I propose an alternative assumption? Now, is the alternative assumption that I'm proposing of any relevance in my context? If it is not relevant in my context, is it relevant in another context or to the research community? So that's a way of coming up. So you don't just propose, you don't just challenge assumptions without proposing alternatives. You try and propose an alternative assumption. And before you write down your assumption, you should think and reflect. Is this assumption, is it plausible? Is this relevant in my community or the audience in which I'm going to face? So in summary, try and ask interesting questions. Identify a good research question. Please remember FINA maps. If you forget maps, then FINA is totally fine. This is really just a guide. It's not a rule of thumb, but it helps guide you so that you remember these things. And it is important also to transform research questions into testable hypotheses. I will shortly try and briefly tell you what the difference between a research question and hypothesis is. Now, what is the anatomy of a research protocol? Now, this is an interesting slide just to give you a summary. During the next couple of weeks, you're going to go through what is contained in a research proposal. So I don't want to dwell so much into that. So it depends on where you're submitting your proposal to. And if you're submitting for a specific grant, then there will be guidelines on how to write your grant proposal. If you're submitting to a university for the award of an academic degree, then you'll follow the guidelines stipulated in the policy, an academic policy of that university. But overall, there is always an introduction, a literature review, a methodology section. If you have done preliminary data or you have done a pilot study, you can include it under preliminary data, a statement of limitations, conclusion, and your references. Now, each of those has different ways, and over the next couple of weeks, you'll learn the details of each and every one of these. But in brief, the introduction asks questions. What is it? Why is it important? How? Then in literature, you ask the similar questions, why and how. In the methodology, it's mainly how. How are you going to do that? Then the preliminary data tells, you ask the question, what do I have? What do I know from my preliminary research or something like that? So this is a summary of a research, anatomy of a research protocol, if I may call it. The next table, well, this is a literature review. It just shows you there are many components of literature review.